Welcome, Dr. Manish Bansal. Welcome, Dr. Vivek. Happy to see you all here.
Good evening.
Good evening. Good evening.
Very good evening to everybody.
Good evening, ma'am.
Good evening. Good evening. Yes, welcome, Rashmi. You are the star today.
Thank you so much, ma'am.
Yeah, all the very best. Dr. Manish will just wait for a minute or so. Dr. Vivek, you will handle the questions again, okay, from the chat box,
Okay, I'm sure.
right?
Yeah.
Manish, people are joining. Actually, it takes like little time to give entry to everyone. So I think just we'll take a minute or two.
Yeah, absolutely fine. Absolutely fine.
So your OPD is over. At warm welcome again to everyone in this fourth session of Eco Made Easy. Let me begin with my heartfelt thanks to our program coordinator, Dr. Rakesh Gupta, for all his inputs and help, and to my lovely moderators, Dr. Vivek Sulere from Indore and Dr. Rohit Tandon. He hasn't joined as yet, from Ludhiana, and thanks to all the lovely audience who shows so much of enthusiasm. And I'm so happy to see you all interacting and answering each other on the Eco Made Easy WhatsApp group. So this is such a wonderful thing that you keep helping each other in finding out that what is the diagnosis and what are the eco findings. So before we begin, let me just tell you that this activity today is being conducted in collaboration with the Delhi branch of the Indian Academy of Echocardiography. So with us today, we have here the newly installed president of the Delhi branch, Dr. Manish Bansal, and we are happy to have him here. And because, that is going to help us a lot, because I really, I admire him, and I'm really fond of his um, uh, um, uh, his what to say, he's such a wonderful echocardiographer. He's such a wonderful knowledge he has, and has been so much involved in academic activities, that I really feel that we'll be fortunate to have him here sometime in our program too. So over to Dr. Manish Bansal. Kindly address the audience for a minute. We'll all be happy to hear from you.
Yeah. Thank you so much, Dr. Hansa, for the kind introduction and the invitation. And good evening to everyone. So, as we all know, echocardiography is one of the most important cardiac imaging modalities, diagnostic modalities, I should say. And honestly speaking, in my opinion, we cannot treat any cardiac patient properly without doing an echo. So it is so powerful a modality. But at the same time, it requires a lot of expertise. And unfortunately, in our country, we don't have many learning opportunities for echo for the clinicians who are interested in echo. And with this, keeping this challenge in mind, Dr. Hansa Gupta and Dr. Rakesh Gupta started this initiative a few months ago under the age of JEROP, and I'm fully aware how helpful it has been to the participants. So it is, first of all, I would like to congratulate you, Dr. Gupta, and the entire organizing team of this activity for the excellent work that has been initiated. Now, from the Academy of Echocardiography, Delhi NCR, it gives me great pleasure to join this activity on behalf of the Academy to collaborate in such a nice initiative. I'm sure collaboration will help us take this activity far wider, will help many more participants. So, thank you for this activity, for this collaboration, and many congratulations. With this, I wish all the participants the best. I'm sure they will get a lot to learn from this activity. and looking forward to the today's session and involvement in future sessions as well. Over to you, Dr. Hansa.
Yeah, thank you. Thank you so much, Dr. Manish. It's lovely to have you here and hear from you. And you are right that without eco, without a proper eco, right? So that's what we are here to
Yeah.
for, and we are trying to learn that how properly an echo can be done and how wonderful it can be in improving the patient outcome. So thank you very much for being here, and without wasting any further time, let us start. And I invite Rashmi Verma to present her case. She's a senior echocardiographer at Marengo Asia Hospital, Faridabad. And Rashmi, I invite you, please go ahead with your case. Rashmi, share your slides.
I hope it is visible to
Yeah,
all
it
the
is visible.
participants.
And now you put it on slideshow.
Okay, ma'am.
Yeah.
So, first of all, good evening, all. I'm thankful to everyone for giving me the opportunity to present a case on this platform. Particularly, I'm thankful to Dr. Hansa ma'am for moderating the case and Dr. Sameer Bahel, my HOD, for his guidance. Here, I would like to share the history of this patient. A 46-year-old female school teacher, very active lady, went on trekking higher altitude to McLeodganj. After her return, she noticed mild shortness of breath. She took it casually and went to Haridwar and many other places. After 20-25 days, she experienced breathlessness on minimal exertion. Her saturation dropped to 85% and then 81%. She came to emergency department. She presented with complaints of shortness of breath, generalized weakness, chest discomfort. She was conscious, oriented, respiratory distress present, and dehydrated. Her vitals showed pulse rate 102 beats per minute, respiratory rate 30, blood pressure 130 by 80 mmHg, SpO2 88% on room air, temperature 99 degree Fahrenheit, chest bilateral V's present. Cardiac biomarker was done and they were normal. Anti-proBNP 30, tropi less than 0.012. D-dimer was not done. Some routine investigations included hemoglobin 11.9, TLC 12.2. ECG was unremarkable with sinus tachycardia. And X-ray showed prominent bronchovascular marking. This is a parasternal long axis view. Left ventricle and left atrium look normal. Short axis view, early systolic notching across the pulmonary artery while putting the pulse wave Doppler. Pulmonary artery size look bigger than aortic root diameter. No filling defect in LPA. PASP was on higher side. It is 50 plus. RARV seems to be normal. And there is no filling defect till the bifurcation of the MPA. We measured the pulmonary artery size and it was 25 mm. This is the zoom view of pulmonary artery, which shows dilatation and no prominent echogenic shadows seen in MPA, as well as RPA and LPA. This is the spectral trace obtained by putting pulse wave Doppler across the pulmonary artery, which shows early systolic notching here. Then we place the first cursor at the beginning of the trace which is here. And second cursor is placed at the peak, which calculated the pulmonary acceleration time 50 millisecond. And a pulmonary artery acceleration time less than 60 millisecond should raise an alarm for the presence of pulmonary thromboembolism in the presence of early systolic notching. It will be early systolic notching and pulmonary acceleration time importance will be discussed in detail by Dr. Hansa ma'am under 60/60 rule later on. As I said, RV systolic function was normal. TAPSE showed 18 millimeter and RV systolic TDI was 11.5 centimeter per second. This is the IVC of this patient. IVC was normal, 1.4 centimeter and more than 50% inspiratory collapse seen. So let me summarize the echo finding of my case. No left-sided pathology with normal ejection fraction, no right ventricle dysfunction, normal RA-RV size, dilated main pulmonary artery that is 25 millimeter, mild TR with PASP 53 mmHg, IVC normal with more than 50% respiratory variation. Important finding is early systolic notching in pulse wave Doppler trace of pulmonary artery and pulmonary artery acceleration time was 50 millisecond. So these were the two important findings I observed during my echo study. So before moving forward, I would like to emphasize here that I did not get any abnormality of right atrium and right ventricle or IVC in my case. If the pulmonary artery interrogation was not done properly, I would have missed the diagnosis of pulmonary thromboembolism. So the idea behind presenting this case was to tell you that each one of us should carefully interrogate pulmonary artery so as not to miss the diagnosis. When I carefully looked for early systolic notching and low pulmonary artery acceleration time, the suspicion of pulmonary thromboembolism became stronger. So to confirm pulmonary thromboembolism, CT pulmonary angiography was advised. And CTPA report revealed bilateral thromboembolism with dilated pulmonary artery. And venous Doppler was also done, and which shows echogenic contents in left short saphenous vein and was non-compressible, likely thrombosed. These are the CT images. Then patient received low molecular weight heparin to begin with as the patient was hemodynamically stable, followed by oral anticoagulants, apixaban. Review of echo of the patient was done after 1 week, revealed no, this I will show first. Normal ejection fraction, there is no deflattened IVS. This is the pulmonary artery Doppler tracing, which shows no early systolic notching. RA-RV size were absolutely normal. There is no significant TR. PA pressure got markedly reduced here. Although the PA size seems to be high, but there is no filling defect. Till the bifurcation of MPA in RPA and LPA. So thank you all for your attention. Now I would like to hand over the session to Dr. Hansa ma'am for further insights and expert knowledge on the topic. And ma'am, over to you.
Yeah, thank you, Rashmi. You presented very well and a very, very relevant case. So before moving forward, I would request, in fact, all the people who are attending this session to appreciate our presenter Rashmi Verma for her hard work. She has really done very well. She studied about it and, volunteered to actually present it. So this is also one thing, which needs some appreciation from all of you, that she's coming forward, and because of her, we are able to learn something very important here. So we have a lot of, reactions here. I would request everyone to say, each one of you should be sending requests, sending appreciation through these, signs which are available, right? This much at least we can do for someone who is helping us learn. Right. So moving forward, let me tell you how this case was different. We had a very different history of high altitude. Okay, I went through the literature and I found that generally heights of 9,000 to 19,000 feet, triggers the coagulation cascade, right? So this history of high altitude is important, but McLeod-Ganj was around 6,800 feet only, right? And so unaccustomed sudden climbing of this altitude may trigger the coagulation cascade, the hypoxia, the increased erythrocytes, increased platelet count, increased platelet adhesiveness. So this history is very important. Be careful to note this history, right? So so the history wasn't very significant though. Then, when she was admitted, if you will note, her presentation was something like an acute infective bronchitis. She was revealing wheeze, mild fever, high TLC. So you would, think that patient is hemodynamically stable and is presenting as bronchitis. So you may tend to, miss the echo findings. Then in the echo, there was no finding except for pulmonary artery. So no RA, RV, IVC, nothing was involved. Nothing was showing any signs. And if she would have overlooked the pulmonary artery in a hurry in the emergency department, she would have missed, right? So the message today here is that never overlook pulmonary artery. Never underestimate the valuable information that the pulmonary artery can give it to you. And as we have learned in our last session, that in each patient, we should be doing suprasternal view. We should try to interrogate the suprasternal view also. So this session, the message is that you should always interrogate pulmonary artery properly. If you will fall in that habit of doing it regularly, you will be able to figure it out very well. I understand that as beginners, it's a difficult thing to figure out pulmonary artery. But if you position the patient well in the left lateral position, we are generally able to figure out pulmonary artery. And if in routine you will do it, and you will see that what kind of trace you get on interrogating pulmonary artery, you will be able to do it easily when the patient is unstable. Because in an unstable dyspneic patient, it becomes a little difficult. Another piece of advice here for everyone is, because this is related to this case, is that all of you should learn to make RV focused views routinely. Okay? Because whenever you will have to assess the RV, our RV dysfunction, RV dilatation, you will always have to make a proper RV focused view. So in a normal stable patient, if you will fall into this habit of making these views, it will not be difficult when such patients with acute pulmonary thromboembolism present to you, right? So so now we move ahead, because today I'll be teaching you some signs. There are around 10 to 12 signs of pulmonary arterial hypertension, and indirectly with these tell us about the pulmonary thromboembolism. And we should go for a comprehensive approach rather than a standalone alone point or a echo marker. So we have to take everything in consideration rather than just focusing on any one single echo finding. So what are these findings we will learn today? And don't try to just listen it. Don't try to take pictures, because we will post it on the, we'll try and request Reena Dua to post them everyday basis, one by one, on your WhatsApp group, so that you can keep it in your phone library. Okay, but try to understand and figure out how they are measured, right? So I will request Reena to please play my PPT, Reena.
Sure, ma'am.
Actually, in chronic thromboembolism or a massive thromboembolism, things are much, much clearer. So the confusion is little less. In our case, confusion was big, because the findings were not there. Presentation was not clear, right? So, all right. Reena, make it on slideshow. Yeah. So let me tell you that why is this disease important? Because a high degree of suspicion is essential, because it varies, it presents to you in a varied manner. The signs and symptoms are not consistent. There are various type of situations wherein it will present. So you should have an element of suspicion in your mind that maybe that you are handling a PTE, right? And also, why is it important? Because it has a very high rate of mortality if left undiagnosed and not treated in time. Hence, it is very, very essential. And while I was making this slide, I also came to know about this fact that it contributes to 1/3 of venous thromboembolism, which itself is third leading cause of cardiovascular mortality. So this is a quite common condition. And we all are observing in our practice that the prevalence of PT is increasing post-COVID. Some say it is vaccine, some say it is what, I don't know. But then, there are several cases which we come across, patients coming from gym, suddenly collapsing and having breathlessness. Somebody gets dehydrated, breathlessness, it is revealed that he has got pulmonary embolism. So we need to figure out, we should have suspicion in our mind, and the suspicion should be really, really high. And to tell you that pulmonary embolism falls in the pre-capillary pulmonary hypertension category. So we have three types: capillary, pre-capillary, and post-capillary pulmonary artery hypertension. So this pulmonary embolism falls in pre-capillary, meaning the problem lies somewhere in the pulmonary artery before the lung capillaries, right? This is to make it simpler. This I've said. So next slide, Rina. Rina, move on to next slide, please. Can you hear me? Okay, till she moves on, I think she's not able. Rina, please move on this slide. Okay, so I just give you a brief idea about, like, what is a massive pulmonary embolism. Yeah. So what are the situations wherein you should be having a high suspicion of pulmonary embolism? Any elderly who is more than 75 years, is in post-surgery immobilized state, post-fracture lower limb immobilized state. Pregnancy is a very, very high procoagulant stage. CKD, malignancy. So in subsequent, sessions, we'll show you some quick, cases wherein malignancy has been playing a very important role. The tumor mass as such gets, embolized to the right side heart. or there is a increased thrombogenicity in the terminal stages, right? And just to mention here, I had a case, and a 90 years old elderly lady. She had a COPD. She had diastolic heart failure, atrial fibrillation. So post hip replacement, she was at home, and she suddenly started becoming breathless. We thought, her COPD is deteriorating, and there was a little inertia for hospitalizing her because of her age. So the saturations were falling. We were trying to, step up the oxygen, the nebulizer and everything. And finally, when nothing was working, this struck my mind, key, is it PT which she's suffering from? And that's what happened. We shifted her to the hospital, CT was done, and it revealed that she was suffering from pulmonary embolism. So one should really have a high suspicion of this disease, because it can be very easily missed. All right, next slide, Rina. Yeah, so role of echo is very important in diagnosis, in risk stratification, in impact management strategies. So we did not find RV dysfunction in our case. There was no other indication. Patient was hemodynamically stable, and hence was treated with only low molecular weight heparins followed by anticoagulants. Had it been RV dysfunction, we would have thrombolized the patient, right? Next slide, please. So I was talking about high-risk PE. You see, shock, hypotension, RV dilatation, myocardial injury, these are all high-risk situations. And this I've already told. Next slide, please. Okay, now this is a very, very important sign. You all must know, all those who appear for the accreditation test also, and otherwise also in your clinical practice when you're doing echo, this is a very, very important sign which may indicate, which may raise an alarm that yes, you are handling a pulmonary embolism. Now, what is this sign? Whenever a short pulmonary artery acceleration time, less than 60 millisecond, is found with no more than a moderate increase in TR pressure gradient, meaning the PASP which you calculate with the help of a TR jet, putting across a continuous wave Doppler across the tricuspid valve. If it is found to be less than 60 millimeters mercury in association with a short PAT, acute PE should be strongly suspected. And this sign has a very, very high specificity, though a low sensitivity, right? So these two, in presence of a mid-systolic notch or maybe other presentation history, one should really suspect and move ahead for the CT pulmonary angiography. Okay, and yeah, so I also wanted to tell you here that what is the idea behind saying that when there is only a moderate increase, because in acute situations the RV modeling does not take place. Okay, so then there's no RV hypertrophy, because in chronic cases, when small pulmonary embolism keeps happening recurrently, the RV gets remodeled, hypertrophied, and it can generate bigger pressures, more than 60. Okay, so when the pressures are not so high and the embolism is still there, you must think it is acute and it's a pulmonary embolism, right? So do not forget this 60-60 sign. Move on. Okay, so what are the signs of RV dysfunction or RV strain? We have McConnell sign. I'll explain each of them. RV end diastolic dimension of more than 30 millimeters. TAPSE we all record with the help of M mode across the lateral leaflet of the tricuspid valve. RV systolic velocity measured with the help of tissue Doppler imaging. If less than 9.5, some places it is written 10, then you label it as reduced RV function. I have not mentioned, I forgot to mention about the TR and the, so the TR velocity is also important to measure the pulmonary artery hypertension, because whenever there is an embolus, if the embolus is very big, it is going to obstruct and increase the peripheral vascular, the pulmonary vascular resistance, right? So whenever the resistance is increased, the PA pressures are increased, and it will bring all these symptoms related to that. D-shaped LV cavity, flattened, this is all RV strain because the pulmonary vascular resistance has increased. So D-shaped LV cavity, flattened IVS with paradoxical motion, okay, which you may, come across as jerky IVS, and reduced GLS of mid-free wall as well as apex of RV on strain imaging. So don't worry, I'll explain it one by one in my subsequent slides. Move on, Reena, please. Yeah. So this is the McConnell sign. Reena, I would like whenever I'm talking, you please use the cursor to show them the exact site actually. So I'll come with this schematic diagram first. Okay, now what is McConnell sign? It is akinesis or hypokinesis of the mid-free wall of the RV. Reena, on this schematic diagram, the mid wall RV, yes. No, the mid wall of RV. Yeah, free wall, yeah, yes. So these arrows, they are pointing at the mid free wall of the RV, right? So they become akinetic or hypokinetic, and the apex of RV, right? This becomes hyperkinetic, right? So this is called as McConnell sign and has been considered as a marker of pulmonary embolism or pulmonary hypertension, though this McConnell sign is not synonymous with pulmonary embolism. It can be also seen in the pulmonary hypertension. All right. So, and this, why is this happening? This is happening because this RV apex is tethered with the hyperdynamic LV, and when the LV is contracting vigorously, it is pulling the RV apex along with it. So it appears hypercontractile. Whereas it has been found, currently when the strain imaging has become available, various studies were done, and it was found that the apex as well had a reduced GLS. So the entire RV free wall was hypokinetic, not just the mid free wall. All right. So this is an important sign which you should remember otherwise also. And you may, look for it. Try to appreciate, in a normal case also that how things function. So you will be able to catch the abnormal one. Next slide, please. Okay, now this is a very important thing, you will, this will help you in improving your concepts about the evaluation of the right ventricle size. So in acute massive PE or the chronic PE, you can have such kind of situations. So understand what is normal. So normally the RV is 2/3 the size of LV. You can appreciate it very clearly here. The RV is 2/3 the size of LV. Okay. So now what is the mild RV enlargement? It is similar to LV, and although it is not looking like that, but it is same size, and it starts sharing the apex. Generally, the apex is only made up of LV. All right. LV apex. RV does not form the apex. When it starts forming the apex, it is a mild enlargement of RV. Then moderate RV, RV becomes larger than LV. Okay, so you learn what is mild and what is severe. Okay, so severe is like, it is very large. See, it is very, very clearly evident. There's nothing which is not visible. Okay, a large RV and a D-shaped septum. And with a D-shaped septum, meaning it is going towards the LV, compressing it. Next slide, please. Okay, this is another, sign of pulmonary hypertension or embolism, in which this is a short axis view. Okay, and Reena, just show them the flame, which is seen as pulmonary regurgitation in the flame, red flame, correct. Okay, so this is the short axis view. When you put a color Doppler across the pulmonary artery, you will see a jet going towards the probe. Okay, this is pulmonary regurgitation. When you interrogate it with the continuous wave Doppler, you will find this kind of spectrum, this kind of trace. And the end velocity is helpful in measuring the pulmonary artery diastolic pressure. But here we are not assessing that. We are assessing the early diastolic PR velocity. The 0.1 is what we are interrogating here. Reena, just put at the cursor at 0.1. Down, down, down. Yeah, correct. So this is 0.1. This is the high early diastolic. What we were interrogating for PADP was late diastolic velocity. Okay, end diastolic velocity. But here what I'm talking about is a early diastolic PR velocity. If it is more than 2.2 meter per second, it marks elevated mean pulmonary artery pulmonary artery pressure. All right, next slide. This is the eccentricity index. So I'll tell you, Reena, so the top this thing is of the normal. Okay, top two views are of the normal diastole and systole of short axis. Got it? And the lower one shows the enlarged one. You can appreciate the RV is quite enlarged. So how will we measure the eccentricity index? When you measure a line which is parallel to the septum is D1. Parallel banao, Reena? Right. This is the parallel. So this is D2. The one which is perpendicular to septum is D1. So D2 upon D1. Generally, if you look at the upper the box, you will see that both are equal, almost equal. But here, the D2 is bigger than D1. So the eccentricity index is abnormal, more than 1.1. Okay, so you can't remember all these indices, but you can always, make a chart and keep it in your pocket or in your chamber, echo chamber, and you can always refer it to it. But if you can refer only if you have an idea that, yes, I have to measure the eccentricity index. Once I'm confused, sometimes things are very, very obvious. So it's not necessary that you keep measuring all these 10 signs. But yes, something is very, very apparent. You have seen that you can very well see here that the eccentricity is lost. Okay, so but you should have an idea that this is the kind of thing which happens. Next. Yeah, so this is what Rashmi was telling about, and this is how we measure the PAT. This is again the short axis view. You put a either in the RVOT or pulse wave either in the RVOT or in the pulmonary artery. Okay, and this is the first trace which you have got. The first cursor at the top, start. Yeah, and the second is at the peak of the trace, and this distance is evaluated in milliseconds. So generally, if it is less than 105, it is indicative of pulmonary hypertension, and when it is less than 60 in presence of TR gradient less than 60, then that comes 60-60 sign. And this is where we also get the mid-systolic notching. She has explained it already, so I'm skipping this. Move ahead. Okay, this is early systolic notching. Reena, just show that the pulse wave is put in the RVOT. Yeah, okay. And this is how you get the trace. You are getting a systolic notch. It is because of the reflection of the waves due to increased, the blood is flowing. Please mute yourself, whoever is, whose audio is not blocked. Please mute yourself. Okay, so this systolic notching happens because of the reflection of the waves. Why reflection? Because in the flow forward, you are meeting a resistance. So some of the waves are reflecting back, and this is what is a notching you are obtaining, and then again forward flow happens. So this is the explanation of this mid-systolic notch. So this is an indirect sign that the resistance is increased due to obstruction by emboli. Next slide. Next slide, Rina. Okay, this is the diameter. So this is again measured in short axis, and a very simple way I will tell you. They have said that measure it, but normally you can make an assessment with the aortic root diameter. Rina, just show them the aortic root. Yeah, aortic root. No, the aortic root, the circumference of the aortic root, which it is shown here. So this is pulmonary artery, and the adjacent is the aortic root. Okay. Yeah. So you compare if the pulmonary artery is generally lesser than the aortic root. So if you find in any case if the pulmonary artery is high, is measuring higher than the aortic, looking higher apparently visually, it is looking bigger than the aortic root, you must think of pulmonary artery enlargement and then start digging into what the cause is. Next slide. So more than 25 is considered to be abnormal. Then this is very important again for the dilatation. This is the ratio of RV to LV, basal diameter ratio. This sign has been given a good amount of significance in the assessment of pulmonary artery hypertension or embolism. So make a good four-chamber view, and just above the annulus, you will measure leading edge to leading edge, RV, and the LV, and you make and you divide RV upon LV size, and if it is more than 1 at end diastole, it suggests RV dilatation. Remember this sign. This sign has been given good importance in sensitivity and specificity. Next slide. Okay, so this is a summary of it. We'll send it, and I think it's already, we have spent a lot of time. Dr. Rakesh has to join. And so we'll send you this. You can read this and learn, because all the signs are given together. All right. So thank you very much. And if you have any questions, you can send in the chat box. We will handle it later. And I would now request Dr. Rakesh Gupta to please join us. And he was busy in his OPD. And he will now continue forward with mitral regurgitation, which we discussed in the last session also. And this time he will tell us the more advanced measurements of mitral regurgitation. Over to you, Dr. Rakesh. And would you like to speak something about,
very much.
Yeah. Would you like to speak something about our program on 17th?
Yes, definitely. Thank you. We are launching a very interesting symposium on 17th August at Hotel Ashok from 9 a.m. to 5 p.m. Whosoever is getting connected today will be sending a link for registrations. If you are interested, please join that particular link, complete the data, and the registration is complimentary but mandatory for logistic reasons. So that's what, and it is very interesting. Like, we are talking of atrial fibrillation, we are talking of imaging modalities in CAD detection, then heart failure, then multiple cases, and finally the cardio obstetrics. So I'll share that complete program on this group. And before I close, I'd like to show you that complete program. Well, moving on, an excellent presentation for a pulmonary embolism. I think we have covered everything in pulmonary embolism. There are a couple of new things which is really happening. One is RV strain, which has come up really well over a period of time. And then one paper which is recently published in July 2025 in JACE, also talking of pulmonary embolism. Anyway, those are way advanced than you think in your clinical practice. If you practice whatever Dr. Hansa said, I think you've done almost 99% of evaluation in pulmonary embolisms. Moving further, just one slide why we need and intervention before it becomes severe in mitral regurgitation. Look, as soon as the regurgitation leads to LV dysfunction and dilatation, look, what is the cumulative incidence of mortality and morbidity? It dramatically increases over a period of time. Till it's not dilated, till it's not dysfunction does not has happened, it is still going on strong as far as things are concerned. So we need to identify what is my severe regurgitation is. As far as anatomy, it was discussed like we have an annulus, we have AML, we have PML, we have a papillary muscles which are attached to cords to the leaflets. So these are the papillary muscles attached to the cords to the leaflets. Then we had a classification talking of primary versus secondary. Then we have Carpentier classification. Then we talked about acute versus chronic MR. And this primary and secondary, acute versus chronic MR, we said, like there are certain conditions where we do not look for evaluation, like flail leaflets, traumatic rupture of papillary muscles, traumatic rupture of mitral valve leaflets. So certain conditions where we don't need a severity evaluation. And this is what is most important for interest is myxomatous leaflet, which may be corrected by surgical correction long time back. Now they are being taken care by mitral clips. I'll try to show certain clips on this. Then degenerative, they need surgical replacement or repair. And then other miscellaneous, when we have a dilated annulus ruptured cord. Recently, I came across a patient who had an ischemic MR, traumatic rupture of a cord secondary to ischemia. Irresistant heart failure, not responding. Patient was taken on ECMO. And then while patient was on ECMO, he was taken to cath lab and mitral clipping was done to reduce severity of MR. And once the severity of MR was reduced, he was taken off ECMO and then subsequently went on to a CABG to save his life. So that's what the scenario is happening as on today in especially cardiology and echocardiography. In quantifying mitral regurgitations, we said we have invasive method and non-invasive method. We are going to focus on non-invasive method. And whatever we talked last time was a basic echocardiography evaluation. We looked at transmitral flow velocity, which is increased. Then we looked at the jet signal reversibility, like how much density of this MR signals are present. Higher the density, more was the severity of mitral regurgitation. Increased flow velocity across this mitral valve, that is suggestive of, it's not quantitative, is a qualitative sign of talking about, look, this is patients have severe MR. Then next we talked about the Doppler signal patterns. What are Doppler signal patterns? Normally, the MR pattern is tongue-shaped. If the severity increases, the sharp acceleration time and a slow deceleration time happens. So three things which comes out from this Doppler spectrum pattern by continuous wave Doppler is increased flow velocity, density of a signal, and type of a Doppler spectrum pattern which tells you about severity of mitral regurgitations. Severe, they're always dense. Velocity will increase, not decrease. Shape would be asymmetrical in severe MR. Then jet area versus LA area, that's what we was discussing last time. What we do, we can look at this area of the jet, less than 4, more than 8. But why we only look at this kind of a thing? Because absolutely it is dependent on two important factors, that LV contraction and LA pressures. Suppose my BP is high, I'll be overestimating my jet area. If my BP is low, I'll be underestimating my jet area. If my LA pressures are high, I'll be underestimating my jet area. If my LA pressures are low, I'll be overestimating my jet area. Not only that, the Nyquist limit also makes a mode of difference. Now we keep a Nyquist limit between 50 to 60 or 56 to 61. That's what the Nyquist limit we keep normally to look at jet area versus LA area. But it has got so many inherent problems of calculating severity of jet area. And if the LA is large, we'll be underestimating the severity of mitral regurgitations. But unfortunately or fortunately, majority of people, they are utilizing this particular jet area in evaluation of severity of mitral regurgitations. Then comes the next factor, at what time the emerging jet area is. That's what I was trying to tell you, ejection fraction versus hypertension and LA pressure, which dictates over a jet area. Then same thing, if you measure the LA size along the jet area, mild less than 20, more severe more than 40, and that's give rise to again the severity of mitral regurgitation. But look at this clip. This clip only documents about 20 to 30% or maybe 40% of the jet area versus LA area. Is it correct? On top of that, many people will say this is eccentric jet. We may add one more of it. Even if I take this vena contracta over here, we always classify them as moderate mitral regurgitation, which is not true again. I'll show you over a period of time why it's not true. Then what we looked at, the next factor was, we started looking at vena contracta. At your level, when we are looking at a vena contracta, I always say, please look at a vena contracta in every subject whom we are assessing mitral regurgitation jet. This is what the vena contracta is, small hole through which MR jet is emerging during systole. And this is an example. This is a plaques view. Here is the aorta. Here is the LA. And we try to look this in systole. Look at the cursor is at the level of systole. The cursor is at the level of systole. So we look at the space between which this is originating. Less than 3, more than 7 is considered as severe. Less than 3 is considered as mild. And do it as many times as possible. If the multiple jets are present, which is often seen, then you sum them up. 0.3 plus 0.2, it will become 0.5, again suggestive of moderate mitral regurgitations. This is again a pictorial diagram where we started looking at a vena contracta, and this is what is important. And again, this is dependent on the Nyquist limit, and it's a very narrow range of evaluations. I saw a couple of places where the people are evaluating the vena contracta in apical 4-chamber view. Couple of doctors, couple of my colleagues, they were doing in 4-chamber view. It leads to overestimation of vena contracta if we are doing in 4-chamber view. Live example, we try to hold this clip in systole, and then you can zoom it up to measure the vena contracta. Then we talked about the signs, secondary signs. Always remember, if you have a severe MR, LV has to be dilated. Forget about this. And today when we talk of a dilatation of LV, we talk of a index dimensions more than 32 millimeter per meter body surface area dimensions. So till now, what we looked at it, we looked at density of a mitral regurgitation jet with velocity, 2 jet area versus LA area, and then vena contracta. And that's what we have been using for a long time to evaluate severity of mitral regurgitations. Now let's move on to still more of mitral regurgitations. What is this more of a mitral regurgitation is? We have 3 categories of evaluation of mitral regurgitation. One is a volume measures. Second is a regurgitant orifice geometry. And third is a supportive hemodynamic science. Let's look one by one. Regurgitant volume or effective regurgitant orifice area. This is what is the most important thing in clinical practice is. Doubt time consuming. When you have a doubt, this is what is most handy and helpful in classifying to severity of mitral regurgitation. I'll be very slow. What I've done is, I've gone to 4-chamber view, kept my Nyquist limit between 50 to 60, and switch on my colors to look for these small hemispheres seen over here. Now the question is, I have to measure these hemisphere radius. Hemisphere radius means the point from the valve annulus to the point of first aliasing line. So what do? I move this base scale downside so that this velocity sector or the Nyquist limit becomes 20 and this becomes 100. And that's what we did in this subsequent patients where we moved our Nyquist limit. Not in this picture, it is not seen. We moved the Nyquist limit to 20 to 30. This is our lower time. And then we try to get the best hemispheres. When we get the best hemisphere, this is what, look at the Nyquist limit over here is hardly 38. This is 85. And we get the first aliasing from the tip of the mitral valve leaflets to the first blue line. And this is what the radius is. And I know there's so many things when we do echocardiography. It could not be seen number of times when my jet is eccentric. So make sure your imaging qualities are perfect. And if your imaging qualities are not perfect, please do not try to do this particular phenomena. Otherwise, we land up with multiple calculation and final wrong evaluation. So what do we do next? I looked at 4-chamber view, study the image, switch on the colors, move my baseline down in the Nyquist limit to 20 to 40, and then look for the first aliasing hemisphere. There's multiple proximal isosurface area. PISA is a method. And we looked at this particular radius. Now, putting this radius into this formula, 2 pi r square. So 2 is a constant, pi is a constant, 3.14 into radius square in centimeters. So suppose my radius is 5.5 centimeters. So my radius is in centimeters into velocity of aliasing, that's in centimeters per second. So what we get? We get regurgitant flow multiplied, dividing by regurgitant flow by peak regurgitant velocity of MR jet. So next we are going to utilize continuous wave Doppler to get a peak regurgitant velocity. Then what we get is effective regurgitant orifice area. And from this effective regurgitant orifice area, we get a regurgitant volume. Just trace this Doppler envelope and divide this ERO with velocity time integral of the regurgitant flow. So I'll repeat the step once more. 4-chamber view, study the image, switch on the colors, then first aliasing line, we are going to measure the radius. 2 pi r square into velocity of aliasing. 2 pi r square velocity of aliasing is 39. Divided by V max of the MR jet, you get effective regurgitant orifice area. And the regurgitant volume is when you divide this, multiply this effective regurgitant orifice area into mitral valve, MR VTR. Now the problem is, despite so many calculations, this ERO is a very small figures. The 0.3 or more is considered as severe. Look how many variables are there. Radius, velocity of imaging, aliasing, peak velocity, and the VTI. 1, 2, 3, 4. The 4 variables are there in this particular scenario. So even if you do a one mistake, it's going to create a hell of a lot of issues. Some people, what they did was, they looked at just velocities or regurgitant area pi r square, and then they came out with certain figures. Look, this is how we can get a simplified PISAs. But when we are doing a severity of evaluations, when we want to be sure before we take any step further, And these things are not done in a routine subject. These things are done in patients who have a variability of severity of lesion, something between moderate to severe. And here is a things how this MR PISA versus JET area is considered. Sensitivity, PISA is 100%, specificity is 93%. JET area is only 85 to 80%. So whenever we are in doubt, that's what modality we evaluate in our clinical practice. Now, next thing is, which I do employ in my practice very commonly. What that thing is? Mitral aortic velocity integral ratio. What is this mitral aortic velocity integral ratio? You look at the blood flow which is happening at aortic valve. You look at the blood flow which is happening at the mitral valve. Very simple. You do a VTI of mitral flow, you do a VTI of the aortic flow. By looking at the pulse wave Doppler at the aortic LVOT area, you keep a pulse wave Doppler at the mitral valve area, or you can do a continuous wave Doppler, because whatever the blood which is going into LA because of regurgitation will be coming back in the same next stroke with a diastole. However, less blood will go from LVOT and aortic valve. So what exactly happens? The VTI across mitral valve would be more than the VTI across aortic valve. Only one catch is there should not be any regurgitation. There should not be any stenosis. There should not be any thickened valve leaflets. So those things should not be there. Suppose you have a regurgitation, then you can't do it. Suppose you have mitral stenosis, you can't do it. So if you have an mitral regurgitation, look at the blood flow which is happening through LVOT, look at the blood flow which is happening through mitral valve. And obviously, if the MR is severe, the mitral VTI would be 1.4 times more than the aortic valve VTI. And this ratio of PISA versus mitral aortic ratio has correlated very well with PISA method. Mavir has correlated very well with mitral aortic velocity integral ratio. Now comes the next important thing. Now I'm adding one more variable. We did PISA, we did mitral aortic velocity integral ratio. Now we are calculating a direct volume calculation of regurgitation jet. So what do we look at? We look at the LVOT flow. We look at the mitral valve flow. Now we have to calculate LVOT diameter. Use my pulse wave, how much blood is going through LVOT. Use my pulse wave Doppler spectrum pattern across mitral valve and look at the mitral valve with diameter in apical 4-chamber wave. So the flow across mitral valve, the flow across LVOT, there'll be two different flows. If your MR is severe, the flow across mitral will be more than the flow across the LVOT. And that's what exactly is depicted. So what is, I feel this is a modification of mitral aortic velocity integral ratio. There we were taking LVOT VTI and mitral flow will VTI. Now we are adding a diameter of mitral valve as well as aortic. So here is LV stroke volume is equal to LV end diastolic minus end systolic volume. That is once you do this. But what I feel always is if you look at the LVOT VTI and aortic mitral valve VTI, you can give you better answer, because once you calculate end diastolic minus end systolic volumes, that'll give you ejection fraction, no doubt about it. But this is relatively more cumbersome and it's liable to have more errors as compared to mitral aortic velocity ratios. That is the slide talking about volumes, LV end diastolic volume and systolic volume. And this is a slide which is talking of LVOT diameter into LVOT VTI, mitral aneurysm diameter into mitral valve VTI. And both of them helps you in calculating the regurgitant volumes. And as we understood, What was the regurgitant volume which was significant? When we talked of PISA method, the regurgitant volume is more than 60 ml, which is significant for severe mitral regurgitations. So we learned PISA, we learned Mavir, we learned with direct calculation either by end diastolic and systolic volume, or more preferable is by direct calculation through flow across LVOT and mitral anodes. Now, third important thing is, look at this patient very carefully. There's a jet of MR which is wrapping around the mitral valve leaflets. And this is a very significant thing which is seen in this patient. The jet looks to be trivial or mitral, trivial or mild, but that's not true. The jet is just wraps around across the mitral valve leaflets. You happen to see two different lines, red or blue color, just within leaflets. And when we did a transesophageal echo, the whole posteriorly directed jet was seen in this mitral regurgitations. So next time you happen to see this kind of picture, make sure that you are doing a transesophageal echo. And if you don't have a facility for transesophageal echo, what you'll do? Just move the probe in 4-chamber, 3-chamber, 2-chamber, or by commercial view to see the severity of a jet. I'll not only say in apical windows, go to subcostal window, go to parasol window, and try to make as many bad images as possible. Because once we'll make bad images, and those images will be very helpful when we'll be looking eccentric MR jets. And that's what is known as mitral valve splay. And this is what I was trying to tell you. Look at this 4-chamber. Look at, this is all jet present over here. It's trivial jet going over there all the way. When we rotated my transducer and offshoot views, I could see a severe mitral regurgitation jet, which is seen in multiple different views. Now, the era is not of a 2-dimensional echo. We are talking of 3-dimensional echo in transthoracic windows. So, from splay, move into 3-dimensional echo. This is a picture from our own lab, where we were measuring the MR jet, and now we are looking at the vena contracta. Look at this patient very carefully. This is flail PML. This is AML, and there is no coaptation point attached to it. So, do I need to calculate the severity of MR in this patient? I'm not going to do anything in the severity of MR in this patient, because as it is looked to be severe mitral regurgitations. That was Plaque's window. This is apical window. And we have a severe MR in this patient when we talk of it. But in 3-dimensional echo, what we do now is, we look at the MR at the vena contracta level. We put our cursor line from a tip of the mitral valve to the base of the mitral valve. And we try to look where my tip is cutting at the tip of the mitral valve leaflet. Look, this patient, when we did it, this patient had a MR, which is right, this cursor is at the tip of the mitral valve leaflet. Zoom up this picture and measure the area. Any area measured than more than 0.4 centimeter is considered as severe mitral regurgitation. Look, this was like an innocuous, very small, insignificant. And if you look at these clips over here, you will see that significant MR is seen. And what is this? Is modification of vena contracta. Only thing is, vena contracta we were cutting in one plane. Now we are taking a 3-dimensional area of the vena contracta in this particular plane. That is 3D transthoracic vena contracta. Now we have gone further upon it. Not at your level. I don't say that it will be at your level. What we have been doing in our lab now is, we are going to this 4-chamber view in transthoracic view, take multiple views and drive an area which is consistent of 3 dimensions vena contracta area in 3 different views. And same thing happens if the vena contracta is more than 0.5 in this thing. We call them as 3 dimensions severe mitral regurgitations. So what we learned? We started with PISA, went on to do a MAVIL, then went on to do a regurgitant volume by 2 method, end diastolic minus end systolic. And fourth method is like looking at the LVOT flow and mitral valve flow. And then we went on to do a mitral valve area by 3-dimension slice methods for calculations of severity of MR. And finally, now what we have been doing in our lab is look at the 3 dimensions vena contracta area, taking care of 3 different views. We have to have a hemodynamic science. As I said, we have to have a reasonably good ejection fraction preserved, and LV dimension should be increased in these subset of populations. Again, this is a fixed values which are seen over here, end systolic volume and end systolic diameter, end systolic dimensions versus LS size to talk of severe of MR. Now, another very important thing, the last sign which I always say is, we learned this point over a period of time is, we said this is a Conda effect, severe MR going all the way back to the mitral valve leaflet. This is not the only thing which thinks of a severity of MR. The severity of MR is when we look at this flow of the pulmonic venous flows. Normally what happens is a continuous flow in systole as well as diastole. There is a continuous flow in systole as well as in diastole. But as the MR increases from mild, moderate to severe, the systolic flow starts getting truncated and finally the reversal. And here is an example where there is hardly any systolic flow. Why the systolic flow is not there? Because the systolic jet is touching over back into the pulmonic vein during systole. And even shows a reversal of a flow. And on the other hand, when the MR is not happening, there's a diastolic flow is present. And that has become a very important sign in clinical practice. Look, there is no systolic flow and a huge or large diastolic flow. And if I show this picture back again to you, which I showed a couple of minutes back, I am going to show this picture again. And now you will realize whether my MR is severe or non-severe. I'm going back, trying to go back to this picture again. Just give me a second. No, the picture, yeah. Here's the picture, which does not looks to be, appears to be severe, but if you look at this pulmonic venous flow in the pulmonic veins, it will be getting severely truncated. And that's what's the most important thing in this severity of MR. The added sign is the reversal or truncated flow in the pulmonic veins. Now, this was the picture I was talking about. The severe MR is touching all the way to the pulmonic veins. So you have to look at this pulmonic venous flow in these subset of populations. And whenever you are in doubt, think of this particular phenomena, whether this is true or wrong. So we move on to further. What we talk of regurgitant volumes, effective regurgitant orifice area, and regurgitant fractions, then 3 transthoracic 3D vena contracta and transesophageal 3D vena contracta. These are a few things which have been added in 2025, apart from what we have been learning over a period of time. Now, let me try to show an interesting patient to you. This is a patient from our own lab. Now look at this patient. This looks very simple patient. Severe MR. LV is good contracting. And here is also LV is good contracting. But MR is not significant if you look at the vena contracta and you look for other factors. And if you, now this is a zoomed up picture, many of you will feel this flail leaflet of the PML. This is A2 and P2. And again, this is the functions which is seen over here. Now let me go back and switch over my presentation to one more quick evaluations. Same patient which I showed you a few minutes back.
Guys, please mute yourself. You're disturbing the audience.
Now look at the same patient which you saw a few minutes back. And this patient is, look, severity of MR of this patient. And why I showed you severity? Now this is transesophageal view. I'm right into the center of, I'm cutting at A2 and P2. So we are cutting A2 and P2. And now moving my cursor from this to A3 and P3. Similarly, I'm moving my cursor with colors with A3 and P3. Look how severe this MR is. And now my other cursor is cutting through A1 and P1s. And when we looked at this phenomena, which is severe in all views, we went on to do what? We went on to do a mitral clipping in this patient, which looks to be innocuous to see with. Patient was in heart failure. And this is a picture of a patient before we did a mitral clip. And look, this is a picture of a patient once we did a mitral clips. This is 4-chamber view or mid-esophageal view, and here is at 3-chamber view where we look in the long axis. So both the views, we see a significant reduction of mitral regurgitation in this patient once we did a mitral clip in this subject. So that's what the era of work today is. And that's how we are changing the complete scenario for evaluation of these patients for mitral regurgitations. I'll put my stop over here and take up any questions which you have in mind so that I can answer them very easily.
Great, Dr. Rakesh. It was a very difficult topic, very nicely handled. I think all of us have to will go through it again and again to actually, it needs to be practiced on a daily basis. Any questions, please?
My only take-home message is, if you have a patient where you feel that is severe, you are in a hurry, give that patient a placebo. Call them again after some time. आप ये दवाई खाओ, कल आना. कल आने का मतलब है keep that 1 hour free for you to look at that patient again. Meanwhile, you have a time to read. And once you have a time to read, you can note down your points. Look, I'm not going to become an expert overnight. You're not going to become expert overnight. But once you keep on practice again and again, believe my words, these things will be so simple, so easy for your life that you'll be standing apart from rest of your colleagues. And that's what the need of a time is. I'm really happy to announce 3 of my students, they just got into NHS last week.
Great. Congratulations.
And all 3 of them are echo technicians. Amazing, So if they can do it, why can't you do it? And we are planning to work a 4-month. Today, a day before yesterday, maybe 2 days down the line, I got a request for what? The Canada wants echo technicians. Except India, everybody wants echo technicians. Unfortunately, our law does not allow a technician to practice. But fortunately, majority of world, Canada, USA, Europe, Britain, they want all good technicians they can be exported from our place of work to their places. Is not that wrong? It's horribly wrong. Not only wrong, it's horribly wrong. We have excellent manpower which get exported anytime to any country wherever the people wants them. And we don't have any like kind of a thing in our country. Look, this is what we can have in our country. If a country can have the people from our own people doing an echocardiography, so that'll be the right thing. What we can do is, let me just show you a program which I was discussing a few minutes back. This is what you like to call upon and join this program. And this is not in a pictorial format. This is a final program which is coming up. I'll try to make it bigger for you. So we have a registration from 8 to 9, then inaugural letters, and followed by advances in atrial fibrillation in 2025. Your very dynamic Hansa madam is a facilitator of this program. Then we have an entire session on AF, history and echo evaluation, rate versus rhythm. Can we predict atrial fibrillation in elderly population? We can predict. Can we prevent stroke in these subset of population? Where I'm telling, look, this patient is going to atrial fibrillation. Prevent a stroke, prevent the atrial fibrillation. And that's what we are going to talk about in atrial fibrillation. Second is advances heart failure. Preserved ejection fraction has become very important criteria as on today. So is the reduced. And then we are coming up very innovative idea of stage B heart failure in Indian populations. Next program is, we have advances in coronary artery management issues. So we are talking of echo and evaluation and history. And then we talk of medical management versus surgical management versus intervention management. And the chairman, Dr. Sethi, comes out with the idea, look, what should be summarized in day-to-day practice? And then we celebrate our 25 years of existence in teaching in echo from G. Once we are done with the lunch, we have a multimodality, a bag of multimodality imaging full of multi-interesting cases. And 6 of them are presenting these cases from all over India. Next, you would not like to learn what is multimodality imaging for CAD detection in 2025? I've given a task to talk of stress echocardiography. I'm very fond of stress. I'm very fond of doing a stress and taking the stress and giving the stress also.
And giving the stress.
This is what the outcome of the stress is. Then we talk of a coronary CT. Then we talk of a nuclear scan. And then finally the bombshell comes from interventional cardiologist. He says, you're all fool people. I'm the best. My coronary angiogram is the best. So we have to defend ourselves. Look, we are also there. You're not only the one who exists on this world. Then next comes, very interesting, symposium on cardio-obstetrics. What is that symposium? Echo changes in normal pregnancy, hypertension in pregnancy, diabetes in pregnancy, and when the patient comes to your echo clinic with dyspnea, hypertension, palpitation, how do we look at these subset in echocardiography? And can we predict cardiomyopathy in these patients? I'm trying to coin a word with the name of impending cardiomyopathies. And your Hansa madam is going to talk about this peripartum cardiomyopathy. And then finally, who should not become pregnant? Obviously, male are not going to become pregnant. I'm talking of the females. Which female should not become pregnant if they are carrying some cardiac illness? And most of these sessions, their panelists are excellent. We have one Dr. Preeti Gupta. She's a professor of cardiology at Safdarjung Hospitals, leading gynecologist. Then we have our own members who are the panelists of this group. Look, we have Dr. Paliwal from Agra, Malvika Suchak from Mumbai, Poonam Malhotra from AIIMS, Delhi. And we have many of these panelists who are going to share their knowledge about this. Dr. Sthapak from Raipur, Dr. Ranjan Kumar from Patna, Neeraj Agarwal from Gangaram Hospital, Vinay Sharma Fortis Scots. So all these panelists, they are going to share their knowledge about these things which are happening in the practice. We have Dr. Omar from Fortis. Dr. Preetam Gupta is a leading physician in our area along with Dr. Chabra and Dr. N. Jha, Dr. G.S. Gupta and Dr. Panda. And many more, like I just want to name them because you will understand what this program is. Then we have Dr. Rajat Mohan. Then we have Dr. M.D. Gupta from Delhi, Dr. Ashok Garg. We have our own Dr. Vivek Sulere looking at this advances in heart failure. Dr. Vivek Kumar from Fortis Scots, Dr. T.M. Agarwal, who's a secretary of these programs. And finally, the multiple panelists, and the panelists are going to talk about at least a minute in these programs. Dr. Ashok Kumar again from Fortis, Vivek Tandon from Max Smart City, Ashish Saxena from Ludhiana, Tamogna Das from Guwahati, Dr. Rashri Agaskar from Mumbai. So all these people, they are going to share their knowledge on this particular platform. And I don't say this is pure echo, this is clinical echocardiography. And which I expect all of you to join. I'm not saying any registrations, nothing is there. Look, put something new in your clinical practice. That's what our aim is. Stand apart from your rest of colleague in your area. That's what our aim is. With this few words, let me stop sharing my slide and hand over the mic to none other than Dr. Vivek Sulere and Hansa Madam. And she is going to be great in every respect.
Thank you so much. Your appreciative words. Keep me going, keep me going. Thank you so much. And I would also like to thank Reena. Reena, you helped me today for my presentation, for playing the PPT and helping me so much for whatever I keep asking you. I am always grateful to you, Reena. Thank you so much. And before we wind up this program, I would like to invite Dr. Rahul Mehrotra, who is the current Vice President of the Delhi chapter of Indian Academy of Echocardiography. Dr. Rahul is eagerly waiting for his concluding remarks. Dr. Rahul, we have taken so much of time and, we kept you waiting. So we would like to hear from you before we conclude.
Good evening, everybody. And this was wonderful to attend the second part of the session. I missed out on the first part, which was presented by Rashmi on pulmonary embolism. I listened through Dr. Rakesh Gupta and was amazed at his enthusiasm, even at the end of this day, week, and very exhaustive description of mitral regurgitation. We keep thinking that we are quite senior, we know MR, everything about all the parameters, but I could not move away from the presentation because there were new things I could pick up from his presentation. And just to highlight, the volumetric method for analysis of severity of MR just came this week. So this was the latest coming from him. Just 4 days ago, this JS issue has come, and in that, this particular article is there from which he showed the image. So it's really amazing. And I'm also happy to see 80 plus people, even after 9:30 p.m., are joining in and listening to these talks on echocardiography. So it's really a very good idea, very good concept of learning from the comforts of our home, going through these topics on echo, revising our knowledge, brushing up with so much of enthusiasm and energy, even at this time of the day. So it's wonderful. And still he was open to question and answers. So whoever is joining in, I think it is a very good learning platform. We should keep attending these sessions and keep learning more and more. And this is a wonderful platform which I could see. Thank you, Dr. Rakesh, for initiating this concept and taking it forward. And
the credit all goes to Dr. Vivek, Dr. Hansa. All these people are credited for this. I'm not the only one.
yes.
And Hansa keeps on giving tensions, You have to do it, you have to do it, and you have to do it.
Very nice. Sir.
I said yesterday I'm taking a class. Today I have a whole lot of work to be done. He said, no, you have to do it.
Yes, yes, we are doing it because you are there. So you have to always,
And now I'm not the only one. Look, this program is also under the banner of Indian Academy of Echo Delhi chapter, Academy of Echo Delhi NCR.
Yes.
So we have so many people, like amazing people like Rahul, Dr. Manish, many more people who are joining us today. And look, that's the need of our hour today. We have to talk of basic and gradually go to advances.
This will take repeated lectures on the same topic, small parts of MR, so that everybody can digest all the parameters.
Correct.
yes.
And we can come up with presentation of MR and then a joint views, what kind of MR it is. Then you can keep on questioning, what is the regurgitation volume? What